Who, when, what, and how. Second part, we'll talk about how does that impact cancer prevention and what can we do in terms of how can we use the germline genetic testing results for cancer prevention. Part 3, we'll talk about in patients who already have cancer, how does germline genetic testing impact their care? And finally, we'll talk about some challenges and future directions in this area. So to start with, let's talk about who needs to undergo germline genetic testing and how do we do that, when do we do that? So some of the basic logistics of germline genetic testing. So I think one of the important things, at least in the United States, we go by the NCCN criteria for germline genetic testing. And if you look at these criteria, they have been updated over the last several years, and they keep on being updated. You know, in the beginning, it was very restrictive, and as the cost of testing has gone down, the criteria have become fairly expensive as well. So right now, if you look at the testing criteria, they suggest that all patients with ovarian cancer should undergo germline genetic testing. If you look at pancreatic cancer, now the criteria recently have been updated to suggest that all pancreatic cancer patients should also undergo germline genetic testing. The criteria now also includes all metastatic prostate cancer patients should undergo germline genetic testing. And male breast cancer patients, they have always been, because the rates of germline mutation in this population is around 15 to 20%, they have always been suggested that they should undergo germline genetic testing. When it comes to female breast cancer, this is where NCCN criteria still recommends that germline genetic testing should be based on family history and characteristics of breast cancer. So for instance, if you have triple negative, then your age at diagnosis may be more liberal compared to if you have a ER positive breast cancer. Now, so this is the overall criteria for germline genetic testing by NCCN. And obviously, in those with personal history of cancer, some of the things that we talked about in women with breast cancer, if they are diagnosed under the age of 45, then they meet criteria for testing. If they are diagnosed between the age of 46 and 50, then they meet criteria if they have a second relative who also has breast cancer or ovarian, pancreatic, or high-grade Gleason prostate cancer. For triple negative breast cancer, anybody diagnosed with triple negative breast cancer under the age of 60 automatically meets testing criteria. And then obviously anybody with, we talked about ovarian cancer, pancreatic cancer, metastatic prostate cancer, they automatically meet criteria for testing. Now in women or men who do not have a personal history of cancer, then you go by the family history. So if they have a family member who would otherwise meet criteria but has not undergone testing, then they should also be considered for germline genetic testing. Also, if you have a family member who is known to carry a pathogenic mutation, then definitely you should be considered for germline genetic testing for that variant. Now, this is an area of controversy. So as you saw, NCCN currently recommends that germline genetic testing should be performed based on family history or age at diagnosis for women with breast cancer. Last year, American Society of Breast Surgeons basically came out and said, well, these criteria are way too restrictive, and a lot of women who are known to carry germline mutation are being missed by these criteria. And so our recommendation would be to test everybody with breast cancer. So this is the American Society of Breast Surgeons guideline basically suggesting genetic testing should be made available to all patients with a personal history of breast cancer. Now, this has created a lot of confusion within the field, at least in the United States, because American Society of Breast Surgeons are a reputable organization as well. And then NCCN, on the other hand, we have always relied on them for the testing criteria. So right now, at least in the United States, some people go by the ASBRS guidelines and test everybody with breast cancer diagnosis, whereas others still continue to follow the NCCN guidelines. Most insurance companies still rely on NCCN guidelines. So in order to look at which of these criteria truly is a better one, this is one of the studies that we performed earlier and published earlier this year. And what we were doing was we compare NCCN and ASBRS criteria. So basically looking at if you test based on NCCN criteria versus test everybody with breast cancer, what are the differences and how many mutation carriers do you truly miss by following NCCN criteria? So what we did was we looked at all women who were enrolled. We have a registry called as Mayo Clinic Breast Cancer Study, or MCBCS. So in this registry, every woman who comes to Mayo Clinic with a diagnosis of breast cancer, they are offered enrollment into this registry. As part of the enrollment, they fill in a questionnaire on personal and family history, and they also provide a blood sample at the time of enrollment. And we have enrolled, we started this registry back in 2000, and so over the last 20 years, we have enrolled several thousand women in this registry, and we have blood sample on all of those. We then performed germline genetic sequencing for 37 breast cancer. Well, it's some of them are breast cancer, some of them are sort of I would just call them cancer predisposition genes. So we looked at 37 genes, and we sort of divided them into 3 categories. So we did not use all 37 genes. We said, okay, what is the percent of women who have BRCA1 or 2 mutation? Then we looked at 6 high-risk genes, which would be BRCA1, 2, CDH1, PALB2, PTEN, and TP53, or additional 3 other genes which are, we know, associated with breast cancer, so such as your CHEK2, ATM, and your NF1. So we looked at those genes as well. And we said, what is the percent of women who carry germline mutation in these genes? So this is the data that came out of that. Basically, we had 2,035 women in this cohort who met NCCN criteria, and 1,872 who did not meet NCCN criteria. Now, if you look at the percent of pathogenic variant in those who met NCCN criteria versus those who did not, you will see that NCCN criteria, basically of all the women with the germline mutation in the 9 breast cancer genes, NCCN criteria would detect 70% of the mutation carriers, whereas almost 30% of mutation carriers would be missed by NCCN criteria. If you look at 6 high-risk genes, NCCN criteria would detect almost 80% of mutation carriers, whereas 20% would be missed by NCCN criteria. If you just look at BRCA1 or 2, NCCN criteria would detect 87% of mutation carriers, and almost 13% would be missed by NCCN criteria. What this really tells you is that NCCN criteria is designed really for BRCA1 or 2 criteria, mutation carriers. And its sensitivity for the 6 high-risk genes or the 9 breast cancer predisposition genes is not that great. And if you look at down below in the panel B, you can see that for BRCA1 and 2, you see that majority of BRCA1 and 2 carriers were detected were within that meeting NCCN guidelines category. Whereas, for instance, CHEK2 carriers, a lot of those who did not meet NCCN guidelines had mutation in genes like CHEK2, ATM, PALB2. You can see it was almost 50-50 divided between those who met NCCN guidelines versus those who did not. So that's kind of what we found. So then that came up with the question is, what can we do in terms of trying to optimize the NCCN criteria? Because if you go by American Society of Breast Surgeons, then you are testing everybody with breast cancer. That's a whole lot of women to test. So on our left is the NCCN criteria. And as you can see, the NCCN criteria, if you look at 9 breast cancer genes, the sensitivity is around 70%. If you look at BRCA1 and 2, the sensitivity is around 87%. On your right is American Society of Breast Surgeons criteria. And you can see that, of course, if you're testing everybody, your sensitivity is around 100%. Now, if you just go by NCCN criteria, you're just testing 48% of women with breast cancer. If you go by ASBRS, of course, you're testing 100% of women with breast cancer. But we said, what would be an optimal cutoff point? And we think if you test anybody who meets NCCN criteria or anybody diagnosed with breast cancer under the age of 65, then you pretty much achieve more than 90% sensitivity for 9 breast cancer genes, 6 high-risk genes. But for BRCA1 and 2, you achieve 98% sensitivity. So that's kind of where our recommendations today stand. And at Mayo Clinic, at least we are following these guidelines right now is we test all women who meet NCCN criteria or are diagnosed with breast cancer under the age of 65. So the timing of genetic testing is another area that I think is interesting a little bit to talk about. So, most of these genes do not cause childhood onset cancer, except for maybe TP53. So for majority of men or women, we only test them during their adulthood. And that's also because, it's very difficult to counsel a child about um, the consequences of the germline mutation and the challenges of so interpreting the results, all of those things. But also, I think the current, at least our recommendations are to test soon after cancer diagnosis and not really wait for a long time. And this is more so important in when you look at in breast cancer. And the reason for that is in breast cancer, at least, and this is one of our studies from 2017, where we looked at mutation carriers. We had 208 mutation carriers, and we looked at those who underwent testing right after diagnosis versus those who decided to defer testing until they took care of their breast cancer, surgery, chemotherapy, all of those. And interestingly, among mutation carriers, if somebody knew their mutation status before surgery, they would choose bilateral mastectomy. So in 76% of women, they chose bilateral mastectomy among those who were aware of their mutation status. Whereas those who did not know about their mutation status, only 14.7% underwent bilateral mastectomy. What this means really is that 85% of women who were later on found to be mutation carriers in BRCA1 or 2 would need to undergo another surgery and undergo bilateral mastectomy if they decide to do risk-reducing mastectomy. So really, I think, in order to avoid these additional surgeries, our practice today is to, as soon as somebody is diagnosed with breast cancer, and if we think that they should undergo germline genetic testing, then we try to do that before they undergo surgery, so that if we find that they carry a germline mutation in BRCA1, 2, or any of the high-risk genes, we could have a discussion about bilateral mastectomy, contralateral prophylactic mastectomy, and avoid any additional surgeries down the road. So the next question that comes up then is what genes to test for? And I think it depends on the cancer type in question. So as you guys are well aware, different cancer have different germline predisposition. And, so when you look at your hereditary breast and ovarian, we tend to think of them as together. Pancreatic has a whole set of different genes that can predispose to pancreatic cancer, similar for prostate cancer and colon cancer. I will mostly be talking about hereditary breast, ovarian, and maybe a little bit about pancreatic, but I won't really go into prostate or colon cancer today. The second thing also is, when we think of what genes to test for, it depends also on the cost of testing. Now, in the United States, at least today, more genes does not necessarily mean more testing. The way these labs have designed their panels is they have these default panels, and for them, the cost is same regardless of whether you order 4 genes or 20 genes. And based on what you ordered, they will run all the 20 genes, but they will, if you only order for 4 genes, they will only report on the 4 genes. So that's kind of what their default modality is, and that's why the cost is not different between 4 genes or 20 genes. But also it's important to think about, what are the implications of testing? And more is not always better. If you are testing for genes with dubious clinical utility, then you are running into areas of, if you do find a mutation in that gene, how are you going to manage your patient? And also there is very good data suggesting that the more genes you test for, the more chances that you will end up with a variant of uncertain significance or VUS result. So to sort of think about, what genes to test for, I think it may be helpful to look at what are the frequency of germline mutations and genes associated with a particular cancer. And this is a study that we published last year in Genetics in Medicine. And so for this study, we collaborated with Ambry Genetics, which is one of the major germline genetic testing lab in the United States. And we looked at testing results of 165,000 patients who underwent testing. And these are patients throughout the United States who underwent testing at Ambry Genetics. We looked at a timeline between March 2012 and December of 2016. And then, so those are your cases. And then for controls, we used, Nomad has exome data from a large number of men and women in the United States who do not have cancer. So these are basically population-based exome controls. So what did we find? So if you look at the green one in this chart is your BRCA1 and 2. The blue one denotes other hereditary breast ovarian cancer genes, including ATM, CHEK2, PALB2, all those things. And then the orange denotes your Lynch genes, and your red denotes other cancer genes. So when you look at female breast cancer, you see that BRCA1 and 2 almost accounts for 2.5%. But a chunk of your germline mutations are noted in other hereditary breast ovarian cancer genes. So these include your ATM, CHEK2, PALB2, all of those. Lynch syndrome genes only account for a very small proportion of all germline mutation carriers among breast cancer. If you look at ovarian cancer, BRCA1 and 2 obviously goes quite high to almost 8% or so. And other hereditary breast ovarian cancer genes account a smaller proportion. Lynch genes definitely account slightly larger than breast cancer, but it's still a quite a small proportion. When you look at endometrial cancer, this is where BRCA1 and 2 is not a major player, but Lynch syndrome genes, as we already know, is a major player in endometrial cancer. Same with colorectal cancer, Lynch syndrome genes are a major player in this area. Pancreatic cancer, you see that BRCA1 and 2 and other hereditary breast cancer genes are both quite significant in this area. And almost more than 10% of pancreatic cancer patients are known to carry germline mutation in these genes. Beyond BRCA2, there are genes ATM, PALB2, now we know are associated with increased risk of pancreatic cancer. And so that would fall into this blue category. Interestingly, if somebody has breast and ovarian cancer, their risk of carrying germline mutation goes up to almost 25%. And you can see that their risk of being a carrier of BRCA1 and 2 is almost 12% or higher. And then they have quite significant chunk of other hereditary breast ovarian cancer genes as well. So that was just the frequency. Now, if you look at what we did was we did what is called as case control analysis and trying to understand what is the risk, the degree of association with breast cancer risk for each gene. And the way we do these kinds of analysis is we look at the frequency of germline mutations in cases, which are your breast cancer. And then we had those population-based controls, and we look at the frequency of the same gene in those controls, and then come up with odds ratios. The higher the odds ratio, the more strong association for a particular gene with that cancer type. So this is for looking at breast cancer. And if you look at 1, that's over here, which is if anything crosses 1, that means the odds ratios are not significant. So you can see that BRCA1 and 2 have odds ratios of almost 5. Now, because these events are so low, you can almost translate these into relative risks, even though these are odds ratios. So you can almost think that BRCA1 and 2 germline mutation will give you almost 5-fold increased risk of breast cancer compared to women who do not carry a BRCA1/2 mutation, or women in the general population. So that's your BRCA1 and 2. If you look at PALB2, it's a high-risk gene as well, and increasingly this is becoming recognized and quite comparable to BRCA1 and 2. If you look at ATM and CHEK2, those are moderate risk genes, and the odds ratios or relative risks are somewhere between 2 and 3. Beyond that, you can see that BRIP1 is also associated with breast cancer risk. we did not find association with NBN and breast cancer risk, but we did find RAD51C, RAD51D, and even BARD1 were associated with increased risk of breast cancer. Now these, there are other studies that we've performed later on which demonstrated that BARD1, RAD51C, and RAD51D are specifically associated with triple negative breast cancer and do not increase the risk of ER positive breast cancer. So to summarize, your high-risk genes are basically BRCA1 and 2, CDH1, CDKN2A, PALB2, and TP53. Your moderate risk genes are ATM, BARD1, your BRIP1, CHEK2, and then if you go further down, RAD51C, RAD51D. We did not find any association with, even though there was slight with MSH6, we don't think that's fairly significant. So for Lynch syndrome genes, at least we did not find any association with increased breast cancer risk. And that is an area of ongoing controversy, depending on what data you look at. Now, if you look at ovarian cancer risk, you can see that the risk of ovarian cancer is almost 10 to 11-fold increase in BRCA1 carriers, similar with the BRCA2 carriers. RAD51C and RAD51D are also associated with increased ovarian cancer genes. But some of the breast cancer genes, such as CHEK2, might not be associated with increased risk of ovarian cancer, and that's kind of increasingly being recognized. ATM, we found odds ratios around 2, but this is difficult to really say whether this gene is truly associated with ovarian cancer risk or not. But beyond that, if you look at the Lynch syndrome genes, we did find association with the MSH2 and MSH6 with ovarian cancer risk as well. Similarly, if you look at endometrial cancer risk, this is where it gets interesting is, if you look at what is the odds of developing endometrial cancer in BRCA1, 2 carriers, really it's very much, if you can see that the confidence intervals are very close to 1. Not as much, but if you look at with MLH1, MSH2, or MSH6 carriers, the risk of developing endometrial cancers in this carriers is almost 20 to 30-fold higher compared to women in the general population. So this is where it really becomes that for these cancers, it is important that that when we are performing testing, that we do test for Lynch syndrome genes. So that's kind of with these associations, I think it's important to keep these in mind when we are ordering genetic testing for our patients. If you have a patient with endometrial cancer, you're more focused on Lynch genes rather than BRCA1 or 2. Whereas if you have a patient with breast cancer, your whole set of genes are very different. And then not just the personal history, but you should also take family history into account when ordering these things. So the next question then comes up is, once you know that, okay, these are the genes that are associated, how do you test? And, for a long time in the United States, until 2011 or 12, the strategy was to do sequential testing, which meant that you would typically, for instance, for breast cancer patients, you would typically test for BRCA1 or 2 first, and then go into testing for other genes if they came back negative. That has changed quite a bit because the cost of next generation sequencing has come down. In 2015, this is the data from 2015 from Alison Curran at Stanford. She found that almost 2/3 of women in the United States were undergoing multi-gene panel testing, and only 1/3 of patients were really undergoing your sequential gene testing. Now, I think in 2020, I would say less than 10% of patients in the United States are undergoing sequential gene testing, and most women just undergo multi-gene panel testing. And it's also important to recognize, what happens for women who previously, prior to 2015, have undergone this testing for BRCA1 and 2. Do you retest them or not? And so we looked at this looking at 122 patients who were previously tested negative for BRCA1 and 2. And then we said, okay, let's do a multi-gene panel on them. And we found that almost 11% of them were found to be a carrier of some other gene mutation. And these would include, most of them included CHEK2, PALB2, BARD1, APC, CDH1, and MRE11A. So it does make sense that if they do meet criteria to retest women who have previously tested negative for BRCA1 and 2 and have not undergone testing for some of these other breast cancer predisposition genes. So to sort of go back to and finalize our what are the genes in breast cancer, at least that we should be considering, I tend to divide them into three categories. And this is from one of our publications in ASCO educational book last year. Um, but even in that, so if you can see that for high-risk gene, I tend to think of BRCA1, 2, CDH1, PALB2, PTEN, and TP53 as the high-risk gene. STK11 is a high-risk breast cancer genes, but it is a syndromic gene and very rare. So a lot of panels will not include this unless there is a specific concern for STK11 mutation. When I think of moderate risk genes, ATM and CHEK2 are your moderate risk genes. Then we tend to think of genes without a clearly defined risk of breast cancer. This is where your BARD1, BRIP1, Lynch, NBN, NF1, RAD51C, and RAD51D come into. But even since writing this publication, this review article, we now tend to think BARD1, RAD51C, and RAD51D as truly triple negative breast cancer predisposition genes. So I think I would now move them to your moderate risk breast cancer category. So not sure what's happening with these lines, but I'm not sure how to remove that, but we'll continue. I think you guys can see this, right?
Yeah.
Yeah, okay. So let's move on to the part 2 of the talk, where we talk about a little bit about what is the implications of finding this from a cancer prevention perspective. And this is mostly for women who do not, or men who do not have cancer. And so since we are mostly talking about breast cancer, this is mostly talking about prevention from a breast cancer perspective. So if you look at the risk, again, going back to the same table, your BRCA, for most of the high-risk genes, the current guidelines will say, you should undergo. And so just to scale back and look at what do we mean by high risk? High risk typically means if your lifetime risk is over 50% or so. And that's kind of what we go by. And on an odds ratio scale, that would be 4-fold increased risk compared to general population. So all of these are your high-risk genes. So if you have more than a 50% lifetime risk of developing breast cancer, then the considerations typically would be either doing screening MRIs, starting at an early age, depending on the gene, maybe 25 or 30, to performing bilateral risk-reducing mastectomy. Now, PALB2 is an interesting because even within, since writing this review, NCCN was, until last year, NCCN would say that there is insufficient evidence for risk-reducing mastectomy. But in this year's edition of NCCN guidelines, now they are suggesting that even PALB2 mutation carriers said there should be consideration for risk-reducing mastectomy, which I think I personally agree with, because it is a high-risk gene, and I don't tend to think of it as a moderate risk gene as ATM or CHEK2. Now for moderate risk genes, and these are where your lifetime risk is over 20%, but less than 50%, the recommendations typically is not to do bilateral mastectomy. I think the recommendations are just to do breast MRIs. Also important in these genes is that these are now we are now finding associations between these genes and the specific type of breast cancer. So it is very unusual for ATM and CHEK2 to cause triple negative breast cancer like your BRCA1 or PALB2 does. Majority of your breast cancer in ATM and CHEK2 are ER positives, and they tend to have better prognosis anyway. So there is also association between the specific subtype of breast cancer from a pathology standpoint that these genes can cause. BARD1, RAD51C, RAD51D, we already talked about being a triple negative genes. For these genes right now, there aren't a lot of specific guidelines in terms of how we should be screening. Now, NCCN tends to say NBN and NF1, maybe we should be doing breast MRIs. We personally think for BARD1, RAD51C, and RAD51D should be included in that list as well. And we have been pushing for that. And we hope that in the next few editions of NCCN, that change will happen where BARD1, RAD51C, and RAD51D will be included as breast cancer predisposition genes, and there will be recommendations for performing MRIs for those. So that's all based on, you look at a gene and you say, okay, you have a mutation in this gene. This is what we are going to do, risk-reducing mastectomy versus all of that. That's all good, but that's just looking at the gene mutation and looking at the risk. But we know that cancer risk in mutation carriers is influenced by several other factors, including specific variant within the gene. As an example, within CHEK2, if you have I157T, a mutation, the relative risk is 1.4-fold. So that does not even cross your 20% lifetime risk threshold. So these women with this mutation have slightly increased risk of breast cancer compared to general population, but really does not meet threshold for MRI screening. Whereas if you look at CHEK2 1100 DEL-C, these women have almost twofold increased risk of breast cancer, and so they would meet criteria for MRI screening. We also know that race and ethnicity is an important modifying factor in terms of how it influences breast cancer risk in mutation carriers. And that we will talk about that a little bit between whites and Black women in the United States. Family history is an important modifying factor as well. So if a mutation carrier has family history of breast cancer, their risk is thought to be higher compared to a mutation carrier without a family history of breast cancer. Now, there are other genetic risk factors that have been identified, and these are like your single nucleotide polymorphisms, which in itself might increase your risk by, let's say, 1.1 to 1.2. It's a relative risk of that. But when you combine a bunch of SNPs and create a polygenic risk scores, then you can easily see that the risks in mutation carriers can be modified quite significantly. And we'll talk about that a little bit as well. So let's talk a little bit about effect of a specific variant. So this is one of our collaborators with the SIMBA consortium. Mayo Clinic is part of this as well. And so we were part of this study where we looked at, and this is looking at prostate cancer, and we looked at specifically in BRCA2 gene, and we looked at where within that gene. So this is all of your prostate cancer. This is the BRCA2 gene. And we looked at where within these genes are your pathogenic variants clustered, and how does it matter in terms of risk depending on where you are located. So within the BRCA2 gene, there is an ovarian cluster that is over here on the top, which is in blue, and there is a breast cancer cluster, which is in orange. So what we mean by that, we already know that certain areas within the gene will lead to higher predisposition to ovarian cancer compared to breast cancer. So if somebody has a pathogenic mutation in the breast cancer cluster region or BCCR, then they are more likely to develop breast cancer rather than ovarian cancer. So we already know about that. But in this study, we found that if somebody has a pathogenic mutation in BRCA2 gene between your 0 and 800 position, then their risk is in fact lower for developing prostate cancer compared to if you have a pathogenic mutation between 800 to your 1863 position. So even within the gene, the risk sort of gets modified depending on where that pathogenic variant is. And so we knew about that for breast and ovarian cancer. In this study, we demonstrated that to be true for prostate cancer as well. So that's one thing that makes it challenging. So it's not just that you can say, okay, you have a BRCA2 gene mutation that your risk is so and so. I mean, in the future, we would anticipate that we will look at these specific reasons and a specific mutation and say your risk because of this specific mutation for prostate cancer is so and so, for ovarian cancer is so and so, and for breast cancer is so and so. Now let's look at the effect of race, ethnicity, and risk of breast cancer. So we looked at, again, using our partners at Ambry Genetics, we looked at 77,900 women with breast cancer in the United States, majority of whom were white, but we had 6,700 Black women, 4,183 Asian women in this cohort. And we, again, did the similar analysis where we looked at controls from general population, but race-matched controls in this case. Again, looking at your odds ratios, which again can be translated into relative risk because of the low frequency of germline mutations. So if you look at BRCA1 carrier down over here, you can see for Hispanic, which is in purple, and for African American, which is in red, the risk is almost, so this is log scale. So even though it does not seem like there is a wide separation between these, there is quite a bit of separation. So you can see that for African Americans and Hispanic, the risk of breast cancer in BRCA1 carrier is almost 16-fold compared to general population race matched. But for whites, it's only around 5-fold. So compared to BRCA1 carriers in whites, if you're a BRCA1 carrier and you're Hispanic or African Americans, your risk is significantly higher. Now, if you go down and look at, for instance, ATM, we know that this is a moderate risk gene. But if you look at ATM carriers and Asians, which is your green line over here, ATM carriers in Asian population does not seem to increase the risk of breast cancer at all, and which is a very surprising finding because this is crossing 1 as well. Same with CHEK2 as well. CHEK2 does not seem to confer increased risk of breast cancer in Asian population. RAD51C, RAD51D as well. So this makes us wonder, there are population-specific differences in terms of how we interpret the results of germline mutations. So should we then be doing a screening, MRI screening in Asian population if they are ATM carriers, if they are CHEK2 carriers? And how do we interpret risk in BRCA1, 2? I mean, if somebody is African American and they have BRCA1 carrier, knowing that they have 16-fold almost increased risk of breast cancer, I mean, do you even feel comfortable just doing MRI? Or would you say all African American women need to undergo bilateral mastectomy? So this is where the results of germline genetic testing really sort of starts getting modified by other factors. So other interesting thing that I think is very important to highlight is the VUS results among different populations. I want to point out to the Asian population. So this is just looking at 12 genes. If you're non-Hispanic white, the chances that you will end up with a variant of uncertain significance is 16%. But if you are Asian, the chances that you will end up with a variant of uncertain significance is 29%. That is almost twice. And the reason for this is because, when we look at variant classification, most of the big databases are based on white population, and minority populations are relatively understudied, and we don't have large databases. So we are not a lot of variants that we see in minority populations have not been classified, and we are just relying on the white populations, and whatever we see in whites are primarily, that's what we use that data to classify variants in minorities as well. So the other thing I wanted to point out is the effect of family history on overall risk in mutation carriers. And this is from Antonius Antonio in the UK, publication from 2014, where he looked at PALB2 mutation carriers and looked at the effect of family history. So if you do not take the effect of family history, these are your percentage of what are the chances of developing breast cancer by a particular age. So lifetime risk of breast cancer almost. This is if somebody has just a mom who is unaffected, grandmother unaffected, and then this is looking at somebody with the mother with breast cancer at age 35, sister and mother with breast cancer, and then just mother and maternal grandmother. You can see that these are unaffected, or these two columns over here. You can see by age 80 years, the chance of developing breast cancer in PALB2 mutation carriers, if they do not have family members, is somewhere around 40%. So it does not even cross threshold for your high-risk genes, because earlier we had talked about 50% as being a threshold for high-risk gene. But you add family history in the mix, and you can see that easily it goes to 60, 70%. And this, suddenly now it looks like BRCA1, 2 carrier. So that's why it's important to take family history into account as well when we are talking about individualized risk estimation. Now, finally, this is again with our collaborators with Simba, is looking at polygenic risk score. So again, there are 313 SNPs today that are known to increase risk of breast cancers. So individually, these only increase your risk of breast cancer by 1.1 to 1.2. But once you start combining these SNPs and look at that, it easily crosses threshold over 2. So out of those 313 SNPs, this is looking at mutation carriers. So BRCA1 carriers, BRCA2 carriers, and looking at if you have, looking at the PRS percentile, meaning what percentile of where do you fall in that whole SNP spectrum. If you do not carry any of these SNPs, your risk is, compared to, let's say, this is your baseline, which would be your 50% lifetime risk. It's almost like half of that. So around this point, if you do not have any of these other SNPs, your lifetime risk is probably around 25%. Whereas if you carry 90 to 95%, if you are in the 90 to 95% of their PRS, you pretty much modify your baseline BRCA1 risk by almost twofold. So you even increase your BRCA1 risk baseline that is with BRCA1 gene by almost twofold if you carry all of these SNPs. So this is where I think the field is moving next, is trying to individualize risk estimation. We are now starting to use things like the polygenic risk score to say, even though you are a BRCA1 or BRCA2 carriers, what truly is your risk and how is it modified by other genetic factors? You know, is your risk higher than a typical BRCA1 carrier or lower than a typical BRCA1 carrier? And that's where these SNPs can be helpful in understanding that. So truly, I think that leads to this point where we say, well, is individualized risk estimation in mutation carriers possible? So you can't really just rely on saying that, oh, you are a BRCA1 carrier, your risk is around 60 to 70%. Because that's like saying, you know, I'm just hitting a note in music and saying, oh, this is the music. Music is complex, right? There are a lot of interactions between different notes. And that's kind of what human body and cancer risk as well is, you know, there are a lot of other genetic factors and, you know, race, family history, those are all indicative of other genetic factors that tend to modify your gene mutation. But add into the risk of, you can add your diet and exercise and other things, and you can easily see how complicated it gets in terms of trying to estimate a cancer risk in any mutation carrier, right? So that brings us to the third part of the talk, where we talk about briefly about the implications of germline genetic testing for cancer treatment. You know, and this is where most exciting thing from a drug treatment perspective is your Parp inhibitors. And Parp inhibitors are very fascinating in that it's really not killing any cancer cells, but it is using the DNA damage defect that happens with germline mutation and sort of leveraging that to lead to synthetic lethality. So Parps basically block your base excision repair. So let's say if there is a single-stranded break because of some DNA damaging agent, what PARPs does is basically, you know, typically that would be repaired by your PARPs, but the PARP inhibitor blocks that. So the single-stranded break then turns into a double-strand break. Now, typically, you know, in a double-strand break, if you do not have germline mutations, that is, you are proficient in your homologous recombination, DNA repair will happen. But now if somebody is a germline mutation carrier, you know, there won't be any DNA repair and there will be cell death. And this is kind of what we are using in cancer cells to lead to synthetic lethality in cancer cells. Now, in breast cancer, this is the Olympiad trial that looked at progression-free survival in metastatic HER2-negative breast cancer in germline BRCA1/2 mutation carriers. PARP inhibitors were associated with improved progression-free survival hazard ratio of 0.5. Recently, updated overall survival data was published, and they did not note any difference in overall survival, but the PFS advantage is definitely there. Same with another PARP inhibitor, talazoparib, which also demonstrated progression-free survival advantage in germline BRCA1/2 carriers with metastatic or advanced breast cancer with PARP inhibitors. Recently, this was in ASCO this year, they looked at TBCRC048 was presented, Nadine Tang at Beth Israel presented this study, and basically looking at PARP inhibitor for other germline mutation carriers, such as PALB2 and ATM. And what she found was, at least for PALB2, so if this is a waterfall plot, we say, and this is reduction in the, or increase in the tumor size. So anything that goes below, say here is 50% reduction in tumor versus this is a 50% growth in tumor. And this is human trials. So for PALB2 mutation carriers, you can see that with PARP inhibitor treatment, at least majority of PALB2 carriers had more than 50% reduction in their breast tumor. Whereas for ATM, CHEK2 really did not seem to be that impressive in terms of PARP inhibitor treatment. So I think PARP will next probably be approved in PALB2 mutation carriers, but ATM, CHEK2, and we know this from our lab studies as well, that they don't really have a lot of signatures for homologous recombination defect, and I think this is just indicative of that. So PARP inhibitors today are approved for metastatic pancreatic cancer. This was based on the POLO trial. Metastatic castrate-resistant prostate cancer with mutations in DNA repair genes, and this includes not just BRCA1, 2, ATM, PALB2, all of that. Metastatic ovarian cancer as well, with BRCA1, 2, or without any germline mutation as well. If you have HRD, usually we know that PARP inhibitors tend to do a great job. So with that, let's sort of wrap up things with the future directions and challenges. And I think, the future directions from a patient perspective, I'm an oncologist by training. So for me, the most exciting part of doing germline genetic testing is being able to use that information for treatment of patients with cancer. And, you saw the data on PARP, but I think PARPs are now moving forward to another phase. And this is recently presented data just earlier this month, in fact, from Mediola trial, looking at this is a phase 1, phase 2, but combining PARP inhibitor with immunotherapy in germline BRCA1, 2 patients. And so these are metastatic patients with who have failed through multiple lines of therapies. And you can see at least there are a bunch of patients over here, again, small numbers, who have been responding for more than 2 years on this combination. And that's kind of a almost unheard of for a lot of these patients with metastatic breast cancer who have progressed through 3 or 4 lines of therapies. So this is definitely exciting, at least for me to think about is, in the future, I think we are looking into novel combinations of PARP immunotherapies, PARP and other drugs, other targeted agents in germline BRCA1, 2, or other mutation carriers. The other side of this is also improving the risk estimation as well. And I think, for the most part, most of our risk are derived from high-risk population, looking at women who have a family history or have multiple cancers, and that's where we derive risk estimates from. Now we are doing population-based risk estimation as well. We have a project going on in our lab right now called as the Carriers Consortium, which uses 17 epidemiological studies within the United States. And we have 32,000 breast cancer cases and 32,000 matched controls. And looking at these kind of large data sets now, we will be able to derive what is the risk of breast cancer in mutation carriers from a population-based standpoint, and not just looking at high-risk population. That manuscript is under review right now, and we should shortly have the data within the next month or 2, I would think, which will also sort of improve our understanding of what is the risk of breast cancer in mutation carriers. And then there is, I think that from a future direction perspective, I think there is a call for more expansion in the genetic testing. Direct-to-consumer tests are now already available in the United States. So you don't really need any physician to order tests now. You could call a genetic counselor and get a testing done through some of the lab companies. And that's mostly because the testing, the cost of testing has come down significantly in the US. Right now, some of these direct-to-consumer tests are available for as low as $200 in the US now. And then there is call for population-based universal screening for germline mutations. So if you look at, there have been several publications that have looked into, and a lot of investigators are now looking into to see that is it cost effective, but also they have found that maybe this will be helpful in terms of, if you look at the cost effectiveness standpoint, by preventing cancer, we are truly be lowering the overall cost, even though there is initial cost of genetics testing. And of all the people, Mary Claire King, she was the one who discovered your BRCA gene and is largely credited for the discovery of BRCA gene. She is a big advocate of screening all young women for BRCA mutation. So this is saying population-based screening for BRCA mutations. But this is all good and exciting, but there are several challenges, and I certainly am mindful of. I trained in Nepal, and I came from that setup, so I'm certainly mindful of. A lot of things that I talked about today may not be applicable to a lot of developing countries, and then the biggest factor in all of that is cost. So cost of testing is a big one, and I do think that cost of testing will come down, and I think that's only a matter of time. As we test more, I think it will come down. In the United States, we have seen that it came down from several $1,000s for BRCA1, 2 to now going down to 200. Now we are getting whole exomes for a few $100s, and so I do think that the cost of testing will come down. But the second question in this is, if we're testing somebody, I mean, let's say if we are testing a patient who has metastatic breast cancer, yes, that information will be helpful for family members. But if we find a BRCA1/2 mutation, do we have access to PARP inhibitors? And so, what is the downstream effect? I mean, are we able to screen everybody? How are we going to pay for, when we say annual MRI screening, how are we going to pay for that? Right? And then the other thing is, do we have enough genetic counseling and genetic counselors and physicians who are trained in understanding and interpreting test results? Because that is also very important, is accurate interpretation of test results. In the US, at least my experience working in cancer genetics, I've seen several cases where inappropriate management was done for VUS results. For instance, for BRCA1 to VUS, I have seen cases where patients have undergone bilateral mastectomies. And so it's a question of genetic literacy and who is going to be responsible for making sure that we are ordering the appropriate tests or screening or surgeries. In that case. And then finally, I think the question of, we had talked earlier about the high rates of US in Asians. I mean, we don't have population-based reference databases, and relying on Caucasian population-based databases for classifying our variants is not going to be helpful. So we need to start sort of thinking about how do we collect data from our that is relevant to our populations in developing countries, in Asia especially. And we talked about the high rates of VUS. So that's kind of what ends my talk. And I'll just summarize some key points. We talked about, today, all patients with ovarian, pancreatic, male breast cancer, or metastatic breast cancer should undergo germline genetic testing. But recognize that NCCN guidelines may not be perfect, and they might miss certain 1/3 of mutation carriers. Our study at least says that NCCN criteria or breast cancer diagnosed with under the age of 65 should undergo genetic testing. Multi-gene panels is the way to go for most of this. And then screening and risk reduction strategies are dependent on accurate estimate of cancer risk, but that's modified by several factors, including race, ethnicity, polygenic risk scores, family history, and the specific germline mutation as well. And then identification of mutation has therapeutic implications now in several cancers, including breast, ovarian, pancreatic, and prostate cancer. And I think, I don't think this would be any controversial in saying that there is definitely an urgent need to boost genetic services and research on germline genetic predisposition to cancer in developing countries. We really don't have data on, population-specific cancer predisposition from developing countries, and we need to really work to try to get large data sets from that area of the world. So, to conclude, I would like to thank, I work in Couch's lab, and Fergus Couch is my mentor in the lab. We have a lot of lab members who are listed over here. I'm also thankful for my funding from ASCO, Conquer Cancer, and Mayo Clinic DRP. And then would like to thank my mentors in clinical oncology and my patients. With that, I'll take any further questions that you may have.
Yeah, thank you, Professor Sid, for that wonderful talk. Now the forum is open for discussion. So if you have any questions, you can either directly unmute your mic and ask the questions, or you can send it via the chat.
Yeah, yes, Prof. Sid, that was an excellent talk. Thank you very much for enlightening us about germline genetic testing. I just have 2 questions to ask. Maybe you can just clarify and expand on that now. The point about the polygenic risk scores, I think that's quite interesting and something that is coming up lately. Yep. Looking at the effect of the modifying effect of SNPs on either the moderate or the high penetrance gene. So like if one has the data, like we have the SNPs sort of coming from the exome sequencings or the cancer panel gene testings, is there a minimum number of SNPs that we need to have before we can calculate the polygenic risk scores?
That's a great question. And in fact, in our lab, we have recently faced this issue as well. So if you look at the BCAC SNP, which is the breast cancer consortium that is sort of, which we are part of as well. They initially started with, I think 70 something SNP, then went up to 130. And if you look at then went up to 313. So the 313 is the full list of SNPs, but really out of those, which are the most significant, I think is there is like 130 or so, which are probably the most significant. If you go back to original studies, it's just the 70 SNPs. If you are willing to just look at PRS, depending on who you talk to. So for instance, Ambry today has a whole set of SNPs as well, and it's only 130 as well. Most labs today will say that if you have those original 78 and if you could get to 130, I think that's good enough. Beyond that, the additional SNPs just change a few things here and there. It's really, you may not need all the 313 SNP.
Right, okay, good, thanks. And then the other thing is like in our practice here now, we have both the panel testing and also the exome sequencing, which we have been offering to patients who have inherited cancer risk. And the observations we have had recently is that we have affected cases, and then even with the exome sequencing, the result comes out negative. So I don't know, what is your, like in your practice, what would be your approach to a case like that? Because that's quite a dilemma that we face, like when we have to counsel the patient, and how do you go about that? If you can just expand on that.
Sure. I think that's something that all of us face is, there will be, when we think of cancer itself, I mean, if you put it down into buckets of what is sporadic versus what is genetic, I mean, at most, I think we think 25-30% are probably have a genetic component. And especially if you look at the inherited component part, that's probably even smaller. So yes, we often end up with, even with patients where we see a lot of, family history, significant family history, and we end up with negative test results. The way we counsel that is we try to sort of say, like, there are several factors, and environment factors obviously is one of the bigger shared factor among family members. And if you have done a whole exome, I mean, if you had done just a limited panel, then I guess the question would be, could you look at polygenic risk scores, or could you look at, doing the whole exome? But if you have done a whole exome and you didn't find anything, then at that point, I think I would try to reassure the patient and say, we didn't find anything from a genomic perspective, and more likely than not, your cancer is probably sporadic, related to environmental and other factors.
Right, okay. Right, thanks a lot.
Yes, Rupesh.
Yeah, so Dr. Sid, thanks for your nice presentation. I have a question, like if a patient comes to your clinic for the first time and you decide to go for a germline mutation testing, do you prefer a liquid biopsy or you go for the tissue sample? So this is my one question. And
sure.
I'll be happy to answer.
So for germline genetic testing, we typically do it through blood, and the blood lymphocytes is the preferred method. Or if you wanted to do, you could even do saliva through where you would be collecting lymphocytes anyway. So that's our preferred method. You can look into tissue, but then tissue is obviously, if you're looking into tumor tissue, for instance, right? So the tissue problem with that is tumors will have its own sort of genetic alterations, right? And so how do you identify which is germline versus which is just tumor related? And you can't tell that, but I think if you're just looking to do germline aspect of things, you would typically go for blood or saliva because those are your clean samples. Now, that does become a problem in patients who have, let's say, hematological malignancies. So somebody has leukemias, right, or other things, and you draw blood, and now you are getting a lot of tumor DNA in the mix, right? So that's where sometimes we do like a fibroblastic skin, so a punch biopsy and fibroblastic skin culture and grow that, and then do germline genetic testing on those samples.
Yes, Parsit. I have another question, which is outside the genes that you all have discussed.
Sure.
What about the vascular endothelial growth factor gene? Is there
VEGF,
any
yeah.
connection, and have you all tried to block the VEGF and anti-angiogenic activities on this breast cancer?
Yeah, yeah, good question. Really good question. I think, when we think of VEGF, I think it's not something that we tend to think of as being inherited, but it's important, it's a key player in basically carcinogenesis, right?
Yeah.
Now, so from a VEGF inhibitor perspective, we do have drugs like Avastin that is supposed to be angiogenesis inhibitor and supposed to be working by blocking the VEGF. But the challenge is what we do not know is, is VEGF the initiating event, or is VEGF a sort of falls into the whole cascade of things when a carcinogenesis is initiated. What I mean by that is basically, when carcinogenesis is initiated, when tumor is growing, it needs a lot of blood supply, and that's where your VEGF gets activated. So it almost seems like it's a secondary event. And by blocking VEGF, then do you sort of get control of carcinogenesis or not? And I think that's still something that is being tried quite a lot. And there has been few successes in that area. And that's where the Avastin comes into. But beyond that, in my lab, we haven't worked on VEGF. We typically, we have not worked on VEGF in our lab. But that's a great question. I think that's an area that is an evolving area.
Yeah, thank you, Prasid. Any other questions from the participants? So since there are no questions coming up, so we will conclude the session. So today we had Professor Siddhartha from Mayo Clinic joining with us. We are talking about the germline genetic testing. It was a very excellent talk. We learned a lot. Thank you, Professor Sid. So for the Sri Lankan participants, I would tell it's a good night. For the Professor Sid, I would say it's have a pleasant day. So thank you very much. Thank you very much for thank you very much for joining with us, and we hope to work with you in future with the Human Genetic Society and the Human Genetic Unit at Faculty of Medicine, Colombo. So thank you very much, and thank you, Rupesh, for connecting Professor Sid with us.
Yeah, you're welcome. The thing is, we are going to start a genetic lab outside the Kathmandu, which will be focusing on this malignant diseases. So Dr. Sid is with us. He's helping us to develop the center. So in the coming future, we'll be listing more news about it.
Okay. So that's very nice to hear. So we will collaborate in future also. And thank you very much for joining with us. Okay, have a pleasant day.
Thank you very much, man. Thank you very much, everyone.
Okay.
Truly appreciate it.
Thank you.
Bye.
Thanks.
Bye.
Bye.